Hi, everybody. Thanks for joining us on our little podcast on being a speech language clinician. My colleague Kimberly Osam will be joining me momentarily. And my apologies on behalf of Kimberly and myself for missing several weeks of recording due to the vicissitudes of life, so to speak. Okay, I will be joined by Kimberly right about now.
All right, welcome back, everyone, and I'm glad to be back. Um, just here to talk about the return. Um, I was out, unfortunately, because of some successive deaths in my family. The first one being my mother, whom I love dearly. And then right after that, my uncle, and then after that, my mom's younger sister. And so, with those three deaths in the family kind of back to back, it did give me pause. And I took some time off. And I just wanted to take a moment to say, I actually would not even be here doing this if it was not for my mom. When I was in school, I had a very severe reading problem. Part of it had to do with just visual. I could not look straight at you as I am trying to do right now because I had such a severe lazy eye in both eyes. They would just roll around like marbles. And it was my mom and my dad also. Um, but mostly my mom, where she would just sit me down sometimes and just take an old oatmeal packet and she would move it back and forth in front of me, and I had to follow it with my eyes to strengthen the muscles in my eyes so I could even just look straight to be able to read. Well, why is that important? Because if you don't read very well, you can't test very well. And if you can't test and read very well, it's harder to get through school. And I did have difficulty, but now you see me here as a speech language clinician, someone who was able to get through a master's program. Um, and it started as a child who just could not read, and also could not tell you the main idea of a story. I could tell you all of the details back almost word for word, but it was my mom who took the time to make sure that I would be able to pass something like a GRE. And so, um, with that said, I just wanted to touch a little bit on her history and also how that kind of related me back to something that I mentioned before and is in the book that Dr. Moses and I are writing together. Um, and it's about sign versus symptom. And again, just to give you a little more background on my mom and why she's so special to me, she comes out of the Jim Crow South segregation. And many of you who are not in Virginia, maybe you had something similar. Maybe you have heard of this, but there was something in Virginia called massive resistance back in those days. And what it basically meant was there was legislation that any schools that tried to integrate here in Virginia, they could be legally shut down, and they were. And my mom was a part of that. As far as the school where she was supposed to be going, it was shut down, and they were not educated for a good period of time. And so, out of that background, out of all of the things that she went through, she made sure that I could do many of the things that legally in Virginia um, we were not allowed to do. And so, when I first heard about my mom's passing, I was not feeling well, but I was looking just as I look now. I wasn't crying, I wasn't outwardly upset. I just didn't feel right. Well, why does that make a difference? And so what I was doing is pretty much what I'm doing right now. I was talking, I was smiling, I wasn't outwardly upset or crying, but I did not feel well inside. It was internal. It was an internal state. And so what I ended up having to do after I went to the viewing for my mother before they even had the official viewing for the public. I just, again, was not feeling well. I left that viewing and I went to the emergency room. By the time I got to the emergency room, again, walked in, not crying, not upset, just told them that I needed to be seen. I was kind of dismissed at first. I was not surprised about that. And when I went back, they were asking me some questions and they were hooking me up to these machines because they're thinking, okay, she's out of here. She's probably drug seeking or something like that. Long story short, once they get me hooked up, they see that my blood pressure is in the 200s over the 100s. And then everybody starts scrambling because from my outward presentation, it was not evident that there was anything wrong with me. I walked in under my own power. I filled out the paperwork they needed me to fill out. I went back, and then everybody started asking me, what is going on? What's going on? And I told them, I just don't feel okay. I just don't feel okay. They went and did put an IV in me, did X-ray, EKG, put medication in the IV. And then finally I told them, well, I'm just coming from the viewing for my mother for her funeral. And then everyone kind of stopped and they realized that this is something that's I'm internalizing and it is showing up on their instrumentation. It's showing up on their instrumentation. And so from there, the prescription actually was to go home and to rest. I wasn't given any further medication, to go home and to rest. And so what I want to share with you guys is before I even went to the ER and I wasn't feeling well, and even after when I came home, I just want to show you guys this really briefly. I was monitoring at home. And I don't know if you guys are able to see that. What I'm trying to show here is that, again, this was the internal state when we actually had some instrumentation. This is outside of the ER when I was trying to monitor what was going on to make sure I did not have to go back to the ER before my mother's funeral. And as you can see, what was happening, and again, this is the same blood pressure monitor that I have calibrated to my manual blood pressure monitor that I use with the stethoscope and I pump up myself. And this is one that I also typically get just regular in-range readings. For those of you who don't know, typically, depending on what your medical background is, a lot of us, if they're saying we're in a good range, we might be in the 110s to maybe 120 for the top number, and maybe in the 60s to the 80s for the bottom number. As you can see, internally, sometimes I was barely at 60 over 40 for my blood pressure. And then other times it would just jump up to like 156 over 115, nowhere near ideal. Why do I bring this up? Why do I show this? Because again, it dovetails into what Dr. Moses and I are kind of writing about in a portion of our book, is that when we treat patients and we try to make inferences about what we think is going on internally with that patient, that we know the reason for a behavior. And we're basing it on something that's right there in the room, in the here and now, something that we can see. And so we say that must have been the antecedent. This is the thing that I saw on the outside precede what happened. And so therefore, this is what caused that behavior. It could be, because sometimes it is, but we have to realize that, again, there are no absolutes when it comes to the internal state of someone. That's internal to them. And we have to consider that it could also be something totally different. It could be something else. And in this case, I bring this up just because the same internal state that was happening with me following the death of my mom was so severe to me internally. This is the instrumentation that expresses it externally, say to the ER doctors or to someone else, to finally know, well, you know what, maybe it's not just that Kim doesn't want to talk right now, or she doesn't want to do this, or she doesn't want to do that. Maybe there is a medical reason behind it. And that's why I sincerely stress this, no matter which population we're treating or assessing or working with, We have to rule out medical first, and we have to rule out that there's something other than that here and now that could be on that patient's mind or in their streams of consciousness. We do not know. We treat patients who do have things like object permanence, something that's not right there in their sight that they could be thinking about or could be contributing to how they are behaving. We do have patients that have the ability to have displaced reference, where they might be referencing to something else in their mind, in their stream of consciousness that's not right there. And so if we limit our focus to just what we can observe, to just what we can see, we're missing what might be going on with our patient. So again, I just said all that to say, yes, I've just gone through a very difficult uh, part of my life, losing three very important people to me in just 3 months, really, of each other. But again, just like I'm smiling while I'm saying that now, it's totally different on the inside. So if we can just realize that that happens to us, we have to lend that kind of consideration to our patients as well, that that can be happening to them, that we aren't the be all end all. We're not the know it alls. We might be experts in what we do as far as our assessment and our treatment, but that patient, they are the experts in them. And so I just really would want to sound a note of caution to any of us that, yes, we do need observation. And that's something that Dr. Moses and I also write about in the book, is that we do use observation to inform our assessment and treatment, but we also cannot close our minds and close the door to that there's more than that. And so I share this kind of personal and private moment because as anyone who really knows me knows that I'm a very private person. But when this happened to me, it actually gave me some pause, and it made me think I have to share this, because this is what we have been trying to argue for all this time, that we really do need to realize that there's a whole nother internal side to our patients that we just do not have access to. Some things we can access through instrumentation, but there's so many others that we cannot. So that's why it's so important to presume competence. As we've said so many times before, and as has been quoted in literature over and over again, just by different researchers, presume competence because it's the least dangerous assumption. Again, that's not our original idea. That's already out there in research. And I'll turn it over now to Dr. Moses to see if he has anything to say. But again, I would just close by saying every smiling face is not always a face that's at peace or at rest on the inside.
I just want to extend my condolences, Kimberly, for the losses you've sustained in this very short time. And on behalf of myself, and I'm sure the audience who has joined us, thank you to everybody for joining us today. On the next little podcast, I'll talk a little bit about a conference I went to. I'm wearing the hoodie from the National Black Association for Speech, Language, and Hearing. We presented at that convention, actually myself and several colleagues, and I'll fill everybody in on the next session. Thanks again for joining us.